Thank you, sir. Thank you for the introduction. So, as I said, I work in a very high volume cataract center. So, we do get cases referred to retina clinic post-operatively. And I will be sharing some of the cases that we saw in our retina clinic. So, this was a 65-year-old male who underwent a routine SICS at our center. And on first post-operative day, he presented with a fall in vision of PLPR. Anterior segment was normal. What we saw in the posterior segment was this whitening of the retina. And you can see on the OCT the inner retinal hyperreflectivity suggestive of some amount of vascular spasm, probably CRAO. So another case who presented to us immediately after cataract surgery. The cataract surgery was eventful, and there was a PCR, and the anterior segment surgeon had the. Yes.
Did you inject, give the subtenal injection?
Peribulbar block. Peribulbar block. Yes, sir. So all these cases were under peribulbar block. So this patient had a PCR and underwent anterior vitrectomy with IL placement in the sulcus. Again, similar picture, retinal whitening, and you can see on OCT the inner retinal hyperreflectivity suggestive of some compromise in central retinal artery circulation. So actually we had a series of 14 cases which we reported in 2019 when we had a cluster of CRAO following cataract surgery. All these patients had a PCR and had undergone anterior vitrectomy, and so we were perplexed. CRAO after cataract surgery have been reported, and basically it could be because of vascular spasm due to anesthetic agent or the adrenaline which we at times use along with the local anesthetic agents, or it could be because of the volume of.
PCR will be the result of maybe you must have had a high intraocular pressure.
Yes, sir, that could be. Yes, yes, sir. Is the so what we so in this series what we identified was, because this happened in cluster, it was all consecutive cases. So what we could identify was that there was some issue in our ETO sterilization, and probably we are contemplating that is the hypothesis because there was some residual ETO which could have led to vasospasm intraoperatively, because all these patients were ETO, and we changed the ETO protocol, and after that we did OCT in all our patients, subsequent patients with who underwent anterior vitrectomy, and we did not get. So probably we were not leaving enough aeration time for ETO, because that's the reason what we got in this cluster. Obviously we could not rule out, because most of these patients.
What happened, did all these patients recover?
No, sir.
Huh?
No, they did not recover.
That's very sad.
Yes. So that's when we investigated what went wrong, and that we could identify ETOs.
Could you check the intraocular pressure at that time?
So at the time of surgery we could not, but post-operative day 1 the pressures were fine. They were on, yeah, because we don't usually do intraocular pressure checkup at the time of intraocular. But none of these patients had. We do get these cases of CRAO post-cataract surgery once in a while, but to get in a cluster of 14 cases in a row, and that to all patients who were undergoing anterior vitrectomy, and so that gave us a clue specific to something which was.
Just a question that once you given the injection, was it a difficult cataract surgery?
In which
After the peripheral injection?
all these patients had PCR, the one which we had reported, right?
Okay, so
That means that.
been a little bit of a
Yeah, but yes, sir. Having said, but what happened was, because this happened in a cluster, we had to search for what went wrong. And once we changed our protocol of aeration time from 6 hours to 48 hours, after 3 days now we are using the ETO. Now we have stopped using ETO altogether. But that suddenly the cases went off. So it was like in a cluster.
You can result into CRA block.
So that is what we are, that is the hypothesis, that it can cause vasospasm. Yeah, that's what we thought of.
Hypothesis needs to be
Proven. Yeah, yeah.
So this injection was given by the same
So in our institute, we have different persons giving injections because it's a high volume center. So we have 3-4 optometrists giving injections. So they were all given by different optometrists. Some of them were not specific to one.
And when you say cluster, it's not of the same, it's only those had PCR.
Those
So
who
they
had
were not on
PCR,
the same day.
not on the same day.
No, so
Those,
it's not
but within a month's time.
So we can't call a cluster.
Within a month's time, like it was unusual to have such a high number of cases within a month's time. That's what something.
How about the anesthetic agent?
We were using lignocaine, sir, in all the patients, peribulbar block.
And how about the bottle? How about the batch size?
Because, sir, we were during this period we might have operated more than thousands of cases, and only in few we could. Batch number hai, sir, but the others were not getting it.
How it you can cause it,
That is what we thought, sir. We don't really know. Only thing is, the positive was that once we changed our protocol, we did not get subsequently, because this was happening very too frequently for our comfort, because that's when we decided.
Because it has caused an angiosperm.
Angiosperm.
And led to a actual CRO occlusion. It is not something that is angiosperm which got relieved and
Yes, not relieved. It causes spasm and then probably. Can I go ahead, sir? Yeah. Okay. So,
Intriguing also.
yeah?
Intriguing and interesting.
Interesting, yes. So, yes. So now we are not using any more ETOs. We have plasma now. So, but that time we were really perplexed what is going wrong. 14 cases in 1 month's time was something which was not.
Did you publish it?
Yes, sir. We published in IGO. Yes, sir. Yes. So this is my third case, who is a 60-year-old male, complained of decreased vision following 1 month of cataract surgery. And his unaided vision at the time of discharge was 618. And when he presented to us after 1 month, he had this fundus picture of localized retinal whitening with hemorrhage in the superior quadrant. And you can see also the disc, the upper half of the disc is also pale, along with sclerosed arteries. Right? The OCT of this patient, you can see that the superior half is showing hyperreflectivity of the inner layer. And this is the montage view of the same patient. You can see some RP atrophy superiorly with scattered hemorrhages. Now this patient, FFA showed superior artery occlusion, along with, you can see this RP window defect which is there in the superior quadrant. Another patient, 19, I'll just come with after this what went wrong in these patients. A 19-year-old male who underwent a sclerocorneal tear repair at our center, and following this he presented with vision loss, and then he had this retinal whitening along with hemorrhage in the superior quadrant. So what was common in both these patients was both of these patients had received subconjunctival gentamicin. So we know that intravitreal gentamicin can lead to inadvertent macular ischemia, but we were surprised that even subconjunctival gentamicin can lead to transscleral absorption, and especially if it is given, if it is given at the area where you have your scleral incision. So
Through the wound into the eye, it's not
So-
transcleral.
So it has been reported in this report of 101 cases where they had 23 cases of macular infarction, and and it has also been proven by animal studies now that it can migrate. So the take-home message is, if first of all we have stopped using subconjunctival gentamicin, if at all you are using, don't give at the site of the scleral incision. So this is the last case. This 60-year-old female who had hypertension, and she underwent routine SICS with IOL. However, you can see on the first post-operative day, she had a DM detachment. You can see on the AS-OCT, and she underwent a DM detachment repair by injection of intracameral air, and this is what was observed on the first after the repair, after the DM detachment was repaired. What you can see essentially is whitening of the retina, which is predominantly in the peripapillary and the perifoveal area, tongue-shaped whitening. And this is typically what is seen in posterior ciliary artery occlusions. And you can see that even on FFA, there is late staining in these areas. And and on OCT, what you can see is that the inner layers are almost normal. So it is mostly to do with the outer retina, and you can see outer retinal hyperreflectivity over here. So this is a posterior ciliary artery spasm which we encountered in a patient who had undergone DM repair due to air, possibly because of the increase in intraocular pressure which has occurred. So retinal vascular accidents are rare but devastating, and some of these may not have improvement in vision. And many of these cases can be prevented if proper intra-op or post-op precautions can be taken. Thank you so much.
Wonderful. You know, there's a lot of learning from all this, and some of the precautions which we may be able to take.
Thank you.
Excellent.
Thank you.
If transscleral migration of
It's only
happens, then we should be very careful even injecting when we are doing a buckling. We do antibiotic wash. We should avoid doing amikacin or
especially if we are creating any tunnel or we are reducing
opening the wound.
opening the wound. So that's when the migration is more. And in the first case, if you can see, it was given the superior quadrant, and you can see that there was a migration, and you can see RP atrophy, and superior half was involved. Thank you.